Everyone, today we are going to be looking at both estrogen and progesterone therapy. We'll cover some menopause. We will look at the menstrual cycle as far as physiology. I've covered that in another video. We're going to cover it again today because we're also going to talk about birth control. So when we look at estrogen, we know it's primarily going to be released from the ovaries. We know that our follicles in the beginning and the first half of the menstrual cycle release a lot of our estrogen. Estrogen is essential for secondary sex characteristics of puberty, and it's also huge when we are trying to have a baby, as it's going to help just kind of keep that environment where we want it as far as endometrium goes. Other things it can do for us, though, is things like bones. It actually is protective, right? So we know it actually decreases our bone resorption, so it's going to decrease that chance. It also helps close the epiphyseal plates with pediatrics and puberty. That's why women in the menopause stage actually lose that protection of that estrogen and they're higher risk for osteoporosis. It can also decrease our LDLs and increase our HDLs, which is great. We know as far as cardiovascular, it actually works. It works with nitric oxide to increase vasodilation, so thus decreasing our blood pressure, and overall more of a protective mechanism with cardiovascular. That's also why postmenopausal women, or women in menopause are at a really high risk for coronary artery disease. Other things we can see is it can be neuroprotective as well, kind of help decreasing those levels of oxidative stress, which we know dementia, specifically Alzheimer's, can be a big risk in menopause there as well. Speaking of menopause, so we really are going to kind of break this down into perimenopause, menopause, and then what happens to our large organs here. So menopause on average age is around 51. And really, when we see this, is we see ovary failure. So the ovaries, since fail, we lose our progesterone, our estrogen levels. Those decrease. Therefore, the body tries to stimulate more on the HPO axis by giving us follicular stimulating hormones and luteinizing hormones, but we just can't really get ovulation to happen. And really, once it's about 12 months of amenorrhea or annual ovulation, we can kind of diagnose the menopause. Now, it can happen earlier or later than age 51, but that's kind of when we're seeing this. So perimenopause, really what's happening is at puberty, we have about 500,000 follicles, right? And we know those follicles are just kind of sitting in our ovary ready to go. We know that follicle-stimulating hormone, or FSH, will make them grow, 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 grow. One of those guys will rupture. We get the luteal phase and yada, yada, yada. Well, when we get to age about 37, we know that we have rapid decrease or faster decrease of those follicles in general. And then by the time we get to menopause, we maybe have 100 or so left. Well, because our estrogen and progesterone levels are decreasing, what happens is that follicle-stimulating hormone and luteinizing hormone will increase, 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 because they're trying to tell my ovary to make more and more of these chemicals, but it's not happening. So what we can unfortunately see is because our FSH levels are high, we're getting all this kind of development of these follicles, and they're never really getting fully mature. That can create a problem, right? Because we might not get ovulation, and because all these follicles are starting to happen, we're getting a lot of possibly release of estrogen, we're getting proliferation of that endometrium, and then we can get what we see very commonly in perimenopause is irregular menses. And that's just possibly can be from that imbalance of the estrogen and progesterone and everything kind of going on here as well. Now, when we get to menopause, again, then we've talked about this, we have ovary failure, and then therefore those levels will be low. When we talk about two big organs here, the ovary and the uterus, the ovary eventually is going to shrink, obviously not release what we want, which is causing kind of all these issues. The uterus itself has issues as well. We know that the proliferation we can see kind of from the estrogen coming from all these follicles kind of developing, but overall that uterus eventually we know is going to shorten, and we're going to lose a lot of that nice lubrication down there, and many more issues moving forward. But we kind of talked about all the adverse things we can see, guys. These patients are now higher risk for osteoporosis, for dementia, for coronary artery disease, and so on and so forth. Now, one of the most common things we see in menopause is vasomotor symptoms. And let me make that clear. We can see this in both perimenopause and menopause. It's usually one of those symptoms outside of abnormal uterine bleeding or amenorrhea that brings them into the clinic, possibly. Now, vasomotor symptoms possibly are from your progesterone and estrogen levels being low, causing maybe the follicle-stimulating hormone, luteinizing hormone to be high, and causing this issue here somewhere. Basically, what happens though is you have an increased raise in temperature, you get vasodilation, you can get diaphoresis, and you can get tachyarrhythmias, or kind of feeling like your heart's racing. Really, where they start to feel this is neck, hands, face, stuff like that. It can happen at night, you get night sweats and everything. Now, there's other things that can come with this. Obviously, there's a lot of neuro problems that can come with this, like depression, but obviously just dealing with this is obviously very uncomfortable. Now, these vasomotor symptoms are one of the most common reasons we're going to give estrogen therapy, which we'll talk about here shortly, which seems to definitely help that out. So speaking of estrogen therapy has really 3 approved uses. One is the vasomotor flushes, which is what we kind of referred to as hormonal or hormone replacement therapy. Again, most common thing we're going to use it for. For GU syndrome of menopause, so this would be kind of the dryness and the roughness and maybe even painful intercourse we see with menopause, we can give estrogen in a topical form, maybe as a jelly or as a lubrication to kind of help out with those symptoms. And then postmenopausal osteoporosis. Things that's definitely not approved for is cardiovascular protectiveness. We kind of talked about how estrogen does help out with that. However, it really hasn't been proven to be super helpful for menopause women that want it for protectiveness there, or dementia protective, as the neuroprotective of dementia. Both are not approved. Now, in general, with estrogen risk, we talk about all the things estrogen can do. So if we're giving estrogen now, we obviously can increase risk of certain things. So one of the biggest things right off the back we worry about is our increased clotting. So estrogen has been proven to increase clotting factors like factor 10, factor 7, and many others. Therefore, if we're giving estrogen therapy, you want to be very careful who we are giving it to, right? We really want to weigh out the risk versus the benefits. Elderly women that maybe have a risk of clotting, like MI, PE, anything like that, we want to be really careful. DVTs, VTEs, any of those things, be very careful giving estrogen for those patients. As far as cancer, we do know that it does increase our risk for endometrial cancer, because it's going to cause proliferation of the endometrium as it does during a normal cycle. That's why a lot of times what you can see is we'll give estrogen with progesterone. Now, progesterone itself doesn't really do much in this hormone therapy kind of thing, but it does ideally counteract the effects of estrogen on the endometrium. Now, if your patient has a hysterectomy, really no reason to worry about this as much, but if they still have our uterus and we still have the endometrium, we want to be careful about the increased risk. Other things it can do is it can cause issues in the neural system like depression and just kind of other different psychiatric things that we might see. It can definitely cause nausea, which is pretty extreme at first, but will get better over time. As far as the breast, possibly breast tenderness, and other things like that. We know, obviously, in general, estrogen can increase our risk for breast cancer as well, so we want to be watching that. Next is progestin or progesterone, which is the friend of estrogen. So progesterone primarily released from the ovary, which we know in the luteal phase, we see a lot of progesterone released, and we're going to cover all these phases here in a second. Luteal phase, we know, is coming from a luteal cyst, right, which is releasing a lot of that progesterone, going to the endometrium and giving it all the nice things it wants for proliferation, vascularization. It's giving it release of secretions, really everything that we would want if we're going to have a baby. Outside of that, though, progesterone can do other things. So it makes, during pregnancy, it makes the female more sensitive to respiratory rate, so they might have more of a higher respiratory rate. Therefore, the overall PCO2 or partial pressure of carbon dioxide is actually lower in these patients. So if you were to get an ABG or VBG in the hospital, you would notice that that is just normal and where they live at. Along with that, they actually live at a higher pH because they're releasing more sodium bicarbonate. As far as the temperature, we naturally increase the temperature of the body during this with our progesterone in the body. And last but not least, with the muscle. Well, it actually relaxes. The idea here is it relaxes our uterus, therefore decreasing the chance of contractions and expelling the baby, right? We don't want preterm labor. The other thing, though, is it doesn't just work on that smooth muscle. It works on many other smooth muscles, which is why progesterone or ladies that are pregnant, a lot of times get constipation because this is slowing down all the smooth muscle. For uses, guys, we talked about using it in hormonal therapy to counteract the negative effects of estrogen. It can also be used in any kind of issues with menses, whether that's amenorrhea, so no bleeding. We can do a progesterone test. We can try it out there. We can also use an abnormal uterine bleeding because hopefully it will counteract the effects of all the estrogen that's causing the proliferation and the breakdown of the endometrium. It can be used in different kind of forms of birth control, which we'll cover. It can be used in emergency contraceptive, which we'll cover. And it can also be used for IVF therapy as well. So let's quickly go through our cycle here. We're going to go through this, and then I think if you understand this, birth control will make way more sense. So when we go through a typical cycle, it's usually around 28 days. Now that can vary, obviously, person to person, but typical is 28 days. Midway point is going to be 14, and we call that ovulation usually. So if you break it down, where 14 is kind of midway, we kind of have our first half and our second half of our cycle. Okay, and each half's here, many different things are happening. We're really focused on two different organs where we're seeing a lot of change. We have our ovary and then our endometrium, which is that inner lining of the uterus. So what happens, we'll talk about the HPO axis, but we know we have our hypothalamus, which then talks to our pituitary gland. They release gonadotropins. Those gonadotropins then tell the ovaries and then the endometrium eventually what to do. So what we have is we have the first few days, which you're going to see last anywhere from 1 to 5 up to 1 to 8 days, is our menses, which is technically the period or the bleeding part. And what happens is that endometrium wall just kind of disintegrates, and then we get the blood because there was no baby in there and there was no reason to keep going. And we'll kind of talk about why that happens, but you'll see there's a huge decline in our progesterone levels that cause this to occur. So that's the start, technically, of the cycle. So what we get here is we get our follicle-stimulating hormone, which makes sense because we're in the follicular phase. Follicular phase is going to talk about the ovary, whereas the proliferative phase is going to talk about the uterus. So our follicular-stimulating hormone basically starts to grow these different follicles in the ovary. Well, over time, one of those follicles is going to be picked, and it's going to be very, very large, and we'll get into that. But we get a lot of these follicles that start developing. Those follicles themselves and help with follicle-stimulating hormone are going to make estrogen, and they're going to keep releasing more and more estrogen. Therefore, our estrogen then is going to talk to the endometrium, and he's going to say, I need you to start growing, get back to where we were right before menses, because we might be having company or something. We need to be ready here. So that's kind of how this is all going on. Now, over time, one of those follicles, like I said, is chosen. He's like, I'm the big guy, big follicle. Well, he's doing so well making estrogen and all this stuff that he basically says, I don't need help anymore. Okay? So when he says that, we get a lot of estrogen being released. Remember some of this, we help for birth control. We get a lot of estrogen released. That tells my follicle-stimulating hormone, I don't need help anymore, right? If you look at these two organs, if my ovary is making everything it needs, then this guy eventually doesn't need to stimulate him anymore. So we're going to see decrease in follicle-stimulating hormone with an increase in estrogen. It's actually the opposite of what we just talked about in menopause, where we have a decrease in estrogen, where you see a lot of high follicle-stimulating hormone because we're not making it. It's trying to stimulate the ovary to do what it's supposed to do. Opposite effect here. Eventually, that follicle will rupture, and what we call this is the luteal cyst, which we get out of this. Or corpus luteum. Now, what happens here is we get this huge surge in luteinizing hormone. Okay, so we were talking about follicle stimulating hormone before. Now we're talking about another gonadotropin, which is luteinizing hormone. So he's going to go huge, big, 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 which we then get this ovum, right, that's going to come out of that follicle, and we talk about this luteal cyst. Basically, all this right here is what we call ovulation. So, again, follicle stimulating hormone to give me follicles, eventually give me more estrogen, then that shuts off. Then we get this huge surge in luteinizing hormone. That follicle ruptures, give me an ovum, and then we get this luteal cyst, and he's like, hey, I'm going to take over now. So now this luteal cyst makes a lot of what we call progesterone. The progesterone, just like estrogen, is going to go talk to my friend, the endometrium, and say, I need you to continue to grow and also get your vasculature going. I need you to get ready because I'm hoping something is going to be implanted here momentarily. Now, if there is fertilization with sperm, obviously that'll eventually meet the egg. And what happens here is the luteal cyst, or the corpus luteum, he is constantly making the progesterone and helping out with estrogen as well, which is exactly what our endometrium wants. Well, he needs someone to tell him what to do. So if there is a trophoblast inside the uterus, it'll release HCG. That HCG then tells the luteal cyst, or the corpus luteum, hey, do me a favor, keep making these hormones because I need them. If there is no baby, basically, then eventually what happens is that corpus luteum stops making progesterone. And that's really where we see menses happen. So our progesterone levels are up, 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 and then that corpus luteum's like, no one's telling me what to do anymore, drop our progesterone levels. Therefore, what happens to endometrium? It basically just gets ischemic, meaning it gets decreased flow to it, decreased oxygen to it. So that endometrium just kind of, not so much dies off, but becomes ischemic. And then we see it break down, which is menses, and guess what? We start over again. And this continuously is supposed to happen, all throughout the month. So I want you to pay attention to where progesterone and estrogen was, because that's essentially what we're doing with birth control. We're giving high levels of these guys, okay? So this is what we call the HPO axis. And this is what was just talking to that cycle. So the hypothalamus is going to release our gonadotropin releasing hormone, which then tells our pituitary gland to release our gonadotropins, LH, luteinizing hormone, and FSH, follicle stimulating hormone, which eventually tells the ovary and these guys to give us estrogen and progesterone. So I want you to understand that if I were to give birth control that is estrogen and progesterone, or sometimes just progesterone, it'll then tell these two organs, I don't need help anymore. That's the idea, right? If we give those hormones and then we shut down my luteinizing hormone and we shut down my follicle stimulating hormone, then we have a less chance of ovulation ever happening. And that is exactly what happens. We increase those levels here in the body, which then tells these guys back here, my pituitary gland and my hypothalamus, I don't need any more follicle stimulating hormone or luteinizing hormone, depending on if you're giving an estrogen with a progesterone birth control or just a progesterone. So that is essentially how that works, and we're going to dive into that a little bit. So side effects and adverse reactions to birth control. Now, this kind of depends on which one you're giving. Now, in general, we do increase our clotting risk. And that's not just because of the estrogen, but that could be because of the progesterone as well. Now, the estrogen we know is easily linked to increasing our clotting factors, which we keep talking about, but same with progesterone a little bit. But it might be safer if your patient does have a risk of this, or you're worried at all about that, to give them just a progesterone pill. It might increase our patient's blood pressure. As far as cancer, we do know this because it's been studied very heavily. Birth control does not have any effect on our cervical cancer. We do know that it might be protective with ovarian and endometrial cancer, and it might increase our risk for breast cancer. Some of the absolute contraindications and relative we want to be aware of. Absolute, so if they obviously have a huge history of any kind of clotting disorders or an MI, CVA, anything like that. Worry about their liver. The reason for that is we know some birth control can induce some jaundice and induce some liver injury. Vaginal bleeding of unknown cause, we worry about that big time because we don't know what we're dealing with. Is this a pregnancy patient? Is this a patient that has a miscarriage? Is this a patient that's bleeding for any other number of reason, which could be hormonal balance itself as well. So we want to be very careful giving them more progesterone or estrogen here. Pregnancy, for obvious reasons, but most birth controls, if the patient is pregnant and we find it early enough, if it's found early enough, birth control won't be super hurtful to that baby early enough, depending on the birth control. Smoker over 35, that's in general. Birth control used to not be prescribed to or weary to prescribe patients over 35 because they just had a higher risk of clotting overall. Well, that's since not the thing. You can do that, but the thing is if they have any increased risk of any clotting risk, smoking, you need to be very careful and not giving birth control to those patients over 35 with smoking. Relative hypertension, because we know it can increase. Cardiac disease in general, because it won't help. Diabetes, because birth control can actually give you glucose intolerance. So if they're diabetic and they already have issues with their sugars, you just want to make them aware of this. Gallbladder, as it can cause gallbladder disease, and then it might increase our risk of migraines. As far as interactions, most meds that induce CYP40 will make these not work as well. So you gotta be very careful if you have a patient that's taking birth control and maybe taking one of those medications because the birth control might not work as well, and then you'd have a second form of contraceptive during this. A good example, one of those meds could be like anti-seizure meds. As far as dosing, it's usually on a 28-day schedule, unless we have long-acting, which we'll go into, but 28-day schedule. And they're taking it once a day and same time every day if we can. Now, these medications are more of our longer acting contraceptives, okay? In general, how each of these work outside of IUD, who has two different forms, they work on the progestogens, Progestogens are just like progesterone. Just think about it like that. They work on kind of the same receptors, thus giving us more progesterone. If you remember, when we look back at the cycle, if I have a lot of progesterone, I never get that huge surge in luteinizing hormone, right? Therefore, I basically prevent ovulation. I also don't get all the effects progesterone has on the endometrium, which we know is all the good effects we get for a baby. So if we don't have any of those effects, then even if sperm does get in there, it's not a great environment for them. So the three we have here, Depo is one. It's an injection, usually good for about 3 months. The Depo injection, again, has a form of this progestogens. Therefore, it decreases my gonadotropins, and that's how you not get pregnant. With all of these, though, we worry about abnormal uterine bleeding and issues with menses, and that's because of the progestogens. I can't say it. In general, progesterone, though, which we're seeing here with all three of these, can cause those issues of abnormal bleeding. And that's really just because if we have this imbalance between our estrogen, we're going to have proliferation and then breakdown of that endometrial layer, and the progesterone itself might not be getting there to kind of counteract that. So we can totally get issues with abnormal uterine bleeding with these, which is a big reason people don't like taking them sometimes. IUD is pretty specific because there's two different forms. We have one that's hormonal, one that's not. The non-hormonal basically gives us the chemicals that are going to be toxic to the sperm, whereas the hormonal is going to have a good degree of progesterone in it, which causes this whole thing. IUDs can be good for up to 7 and maybe up to 10 years. Nexplanon's last one. This little rod goes between the bicep and the tendon, or bicep and tricep tendon. Usually good for about 3 years. Same exact concept here again. We're increasing those progesterone levels. Therefore, we can never get luteinizing hormone. Therefore, we don't get ovulation. Therefore, there is no chance, or small chance, that you could get pregnant. Now, going along with this, I thought we'd cover really quickly just emergency contraceptive pills, or more commonly we see in the store called Plan B. Now, there's different kind of forms of these guys, but the most common are going to be the progesterone-only ones. Plan B is an example of that. And obviously the idea here is, like we've been explaining this whole entire lecture, is that if you increase those levels, well, ovulation should not occur, or we decrease our chances of ovulation occurring in general. So if we take it soon enough, to even up to 5 days after unprotected sex, this might help decrease the chances of ovulation occurring, which again, remember ovulation specifically is when that follicle gets bigger, 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 ruptures, and we get that ovum that comes out, which eventually is what the sperm wants to find. So if we never have that, low chance of getting pregnant. I hope you guys enjoyed this. If you did, give me a like, comment with any questions, and we'll see you next time.